Hi students, now I am going to talk to you about a very important topic, and that is teratogenic exposure of the fetus. Now this is practically a very important topic. This is very important from your INI set exams, from the point of view of your NEET exams, and also from your final year point of view. See, earlier this particular topic was not under this heading. I had taught you bits and pieces of this topic at some places. Now I have compiled all the teratogenic exposures and I'm going to teach you teratogenic exposures at one place. Now, when I'm going to talk to you about this topic, not only am I going to tell you that what are teratogens and what kinds of teratogens are there, what are the effects of various teratogens. We are going to talk in detail about radiological exposure of the fetus during pregnancy, how much is permissible, then what investigations are permitted in pregnancy. We are going to talk about drugs in pregnancy, and that's very important, right? Which drug can lead to which congenital malformation. This is very frequently asked, and this is very important from your image-based questions point of view also. Right. Then I am also going to talk to you about teratogenic infections over here. We are going to do in detail about torch infections, about Zika virus infection, about the varicella zoster infection, and about parvovirus infection. So this is a lengthy topic, but it's a very important topic. You will have to do a lot of writing for this topic. So I would request all of you to keep, some water along with you, and keep different colors of pens and keep your notebooks ready so that for another 2 hours you are just going to be writing a lot, right? Okay. So first comes teratogen. What is a teratogen? A teratogen is an agent which can cause abnormalities either in the form or in the function of a developing fetus. So it is not necessary that a teratogen always causes an abnormality in the form. It can cause an abnormality in the form or in the function of the developing fetus. So a teratogenic exposure, it can lead to fetal loss, it can lead to birth defects, it can lead to fetal growth restriction, and it can lead to impaired neurological performances. Right, so all this can happen with a teratogenic exposure, and we know that so many teratogens, they lead to mental retardation. That is why I'm saying that teratogenic exposure can lead to impaired neurological performance. Now, the effect of the teratogen, the effect is going to depend on which teratogen is there. And it is also going to depend on the period of pregnancy at which exposure happens. If you remember, in the early videos, I had told you that the entire duration of pregnancy is divided into 3 fetal growth periods. Right? The first period was pre-embryonic period. The conventional definition of pre-embryonic period as per the embryologist, because it is the embryologist who divide the entire pregnancy into fetal growth period, is that from the day of fertilization and up till 2 weeks after that. Right? That is what is embryonic period. Please remember that in embryonic period, fetus follows all or none law. Fetus follows all or none law. This means that if there is a teratogenic exposure in this period, either it is going to lead to fetal loss or the fetal will escape injury. Fetal will escape injury and there will be no effect. So you are not going to see any congenital malformations. You will not see any growth restriction. Either it has to be a complete abortion, a complete loss, or the fetus is going to completely escape the injury. There won't be any effect. Right? That is why I was saying that it not only depends upon which teratogen is there, in which period the exposure is happening, that is also going to play a role. Then comes the second period, and the second period is called as the embryonic period. Now, embryonic period is from 3 weeks after fertilization to 8 weeks after fertilization. And I hope you remember that only in growth periods, the reference point is the day of fertilization. Apart from that, every other place, the reference point is first day of the last menstrual period. Now, in embryonic period, the main event which is happening is organogenesis. Right, because main event is organogenesis, therefore, if teratogenic exposure happens, then it leads to maximum chances of birth defects. Maximum birth defects are going to happen if teratogenic exposure happens in this period. So if your question is, which is the most teratogenic period? The most teratogenic period is the embryonic period. Then comes the third period, which is the fetal period. Fetal period. Now, fetal period is more than equal to 9 weeks after fertilization. So, from 9 weeks and up till delivery, we have the fetal period. In fetal period, organogenesis is complete. But growth of the fetus is going to happen. Growth of the fetus occurs during this period, and neurological development occurs during this period, right? So if there is a teratogenic exposure in this period, then there are no birth defects which are going to happen, because most of the times organogenesis is complete, but yes, it can lead to growth restriction. Yes, and it can lead to neurological impairment, right? Neurological impairment. Clear to all of you? So depending upon the period of exposure, we can have various effects. What are teratogens? Please remember, it is not just that the teratogens are always drugs or radiation. Teratogen could be a maternal illness. For example, hyperglycemia. In diabetes mellitus, you get congenital malformations because hyperglycemia is teratogenic, right? So it can be that mother's illness is teratogenic. Then infections in the mother like torch infections are teratogenic. Drug exposure, radiation exposure, alcohol, and even increased body temperature. Increase in body temperature is teratogenic. So if in the first few weeks of pregnancy, if body temperature of the mother rises by more than equal to 1.5 degrees Celsius and it is a sustained rise, then it can lead to cleft lip or cleft palate. So even hyperthermia is teratogenic, right? Okay, now coming to imaging in a female of childbearing age. So just now the patient is not pregnant. We are talking about, suppose you have a female who comes to you in childbearing age and you have to do a chest x-ray. What is the general recommendation? So the general recommendations are that before you perform any radiological examination in a patient of childbearing age, you should always ask about pregnancy. Now, the second thing is all non-radiological examinations, they should be done in the first 10 days of the cycle. That is what is called as rule of 10. So suppose you have a female in whom you have to do chest x-ray because she was having loss of weight, because she was having cough. So then it is better, since it is a non-emergency reason, you can ask her about her periods and you can schedule her x-ray in the first 10 days of the cycle. Because in first 10 days of the cycle, there are least chances that she's going to be pregnant because ovulation wouldn't have happened. But obviously, if you are doing an emergency x-ray, for example, an x-ray after road traffic accident, then this rule doesn't follow. This is called as the rule of 10. And whenever patient is in doubt, whenever patient says, I am not sure whether I'm pregnant or not, then it is always advisable that a pregnancy test should be done out to rule out pregnancy. right? But then the applied question over here. Suppose there is a pregnant female who has a road traffic accident, and this patient was not in the condition of telling you that she's pregnant, and you did a chest x-ray at 6 weeks of pregnancy. Now, what is the next step? Please remember that maximum radiological exposure, which I'm going to tell you just now, which is permissible in pregnancy, is up till 5 rads. Right? And when you perform a single chest x-ray, or even if you perform 2 or 3 chest x-rays, then the exposure is less than 5 rads. So that doesn't mean that by chance if you did a chest x-ray or 2 x-rays, or if you did a dental x-ray and the patient was pregnant, then that doesn't mean you are going to terminate her pregnancy. So next step is continue pregnancy. Do not terminate it. Because with chest x-rays, with dental x-rays, the radiological exposure is much, much less than the permissible limit, which is 5 rads, right? So, overall safe limit of radiation exposure in pregnancy is 5 rads. 1 rad is equal to 0.01 gray. Now, if radiation exposure is less than 5 rads, then there is no risk of fetal loss. There is no risk of birth defects. There is no risk of growth restriction. There is no risk of neurological impairment. And there is no risk of cancers in the fetus. Right? So, if radiation exposure is less than 5 rads during pregnancy, it's absolutely safe. It is not going to lead to any increased risk, right? Now, period of pregnancy and what is the adverse effect seen on radiological exposure. So, if period of pregnancy is first 2 weeks after fertilization and the exposure is more than 5 rads. See, what is safe is less than 5 rads. Safe exposure is less than 5 rads, but if exposure is more than 5 rads, then it will lead to fetal loss. Right? As I told you, in this period, it has to be an all or none law. Either the fetus is going to escape injury or it is going to completely abort. So if exposure is more than 5 rads, then there are chances of fetal loss, although most commonly fetal death occurs when radiation exposure is more than equal to 10 rads. Right? So the upper limit is definitely 5 rads in this period, but if exposure becomes 10 rads, then the chances of fetal loss are more. But then we do not say that, up till 10 rads it's safe. No. Safe is up till 5 rads only, right? Now, then up till 16 weeks, again, the safe exposure is less than 5 rads. Now, if exposure is more than 5 rads, what am I going to get? Number 1, I'm going to get birth defects, congenital anomalies, right? So, congenital malformation. Now, which congenital malformation do you get most commonly associated with high radiation exposure? It is microcephaly. Number 2, I am going to get IUGR, intrauterine growth restriction. Number 3, I can get neurological impairment. And number 4, there is increased risk of cancers. Right? Remember, the most common cancer is a leukemia, which is going to happen if exposure is more than 20 rads. Most common is a leukemia, which is going to happen when exposure is more than 20 rads. Right? But then again, as I'm telling you, upper safe limit is 5 rads. Then if period of pregnancy is more than equal to 16 weeks, then remember exposure up till 50 rads is safe. Right? After 16 weeks of pregnancy, exposure up till 50 rads is safe. But then if you are getting a question that what is the maximum permissible limit, your answer is going to be 5 rads. It is only after 16 weeks, specifically if they ask that after 16 weeks how much can be permitted, then after 16 weeks up till 50 rads can be permitted. But overall, general answer for maximum permissible radiation exposure during pregnancy, the answer is 5 rads. Clear? Now, investigations which are absolutely safe in pregnancy: number 1, ultrasound; number 2, MRI; number 3, dental x-rays; number 4, x-ray which is done for diagnostic purpose. For example, head and neck x-ray, limb x-ray, right? Then remember, gadolinium MRI and CT scans are not done in pregnancy, but by chance there is a very much need of doing a CT scan. Then during pregnancy, if you have to do, by chance it is very much needed, then in that case you are going to use an abdominal and a pelvic shield. And you are going to do a CT scan, maybe of the head and of the head you can do, but not of the abdomen and pelvis. Right? Ultrasounds, MRIs, dental x-rays, chest x-ray, if it is being done for some emergency reason, even in that is same. That is safe. So chest x-ray diagnostic, chest x-ray, head and neck x-ray, limb x-ray, if it is done in emergency, it's okay. Generally, we say do not get x-ray done during pregnancy, but during emergency time, if you have to do an x-ray, then also you can do it during pregnancy. But don't misquote me by saying that ma'am said x-ray can be done in pregnancy, it is safe. No, here I mean these two are absolutely safe. But if there is a need to do, then only I'm going to do dental x-ray and chest x-ray or head and neck x-ray for diagnostic purposes. Clear to all of you? This is if need arises. Now, as I told you, most common birth defect which is associated with radiation exposure is microcephaly. Right? This is what you need to know about radiation exposure. Now coming to drug exposure during pregnancy. Now for drugs during pregnancy, all drugs have been divided into 5 categories. So you put the drugs into any of these categories, right? There are few drugs who are going to come in category A, some in category B, some in category C, some in category D, and some in category X. What do you mean by a drug which comes in category A? Now a drug which is included in category A means its safety is established in pregnancy. So it's absolutely safe during pregnancy and its safety is established. How have we established the safety? Because we have done human studies and we have done animal studies, and in human study and animal study both the safety was established. So if any drug's safety has been established both in human and animal study, it is put in category A. Then comes category B. Category B is safety is likely in a pregnant female. Why we are saying it is likely? Because either in this category, the animal study and human study we are talking about, either we don't have any human study and only animal study results are available, and in animal study it has shown no risk. So if there is a drug in which animal study is showing no risk and human study we don't have any human study, then we put it in category B, right? Or else, if we have both the studies where human study is showing there is no risk, but animal study is showing that there is some risk, then also we put it in category B. So either we don't have human study and animal study results are showing no risk, or we have both human and animal study. Human study is saying no risk, animal study is saying some risk, then we put it in category B. Then comes category C. In category C means teratogenicity may be a possibility, right? And this is because we don't have any human study available and animal study is available and it is showing that some risk is there. So if we don't have human study and animal study is saying no risk is there, we put it in category B. If we don't have human study and animal study is saying that some risk is there, we put it in category C. or we don't have any results at all. We don't have any human result study, we don't have any animal study, then also we put it in category C. Right? So if you do not have any results for studies on humans and animals, you are going to put it in category C. Then comes category D. Now, category D means the drug has risk, but it can be given only under special circumstances. Right? So, human studies are present which are showing that risk is present. Whether or not animal studies are there, it doesn't matter. But if human studies are present and they are showing that some risk is present, you are going to put it in category D. Now, I want you to go back and see over here. Now, if animal studies were there and animal studies were showing that some risk is there and human studies were showing no risk is there, you were putting it in category B. Right? If human studies were not available and animal studies were saying some risk is there, then you were putting it in category C. Now you have human studies which are showing some risk is there, plus minus animal studies. Right? You are going to put it in category D. Is that clear to all of you? Yes? Oh. And category X means there is a definite fetal risk and it should not be used at all. Category X means 100% there are chances of fetal teratogenicity and we are not going to use this drug at all. Now, a very important question is, what are category X drugs during pregnancy? Category X drugs which are contraindicated during pregnancy, they are ACE inhibitors, hormones, use of hormones like diethylstilbestrol, danazols and testosterone, valproate, lithium, isotretinoin, thalidomide, methotrexate, misoprostol, and statins. These are all category X drugs, and not only you should know the names of category X drugs, you should also know to what congenital malformations they lead to. Now, this is a vast topic, and so that you recall and you remember all the drugs in a very systematic manner, that is why I have divided the drugs and their teratogenic effects into certain groups. First group is those drugs which lead to limb defects. Right? Now, the drugs which lead to limb defects, you have to remember two drugs lead to limb defect. Number one is thalidomide. Thalidomide leads to phocomelia. Now, phocomelia is a proximal limb defect. Over here, you are seeing phocomelia, which is a proximal limb defect. Right? It's a proximal limb defect, whereas please remember that in case of amniotic band syndrome, where there is severe oligohydramnios, it leads to distal limb defects. It leads to digital amputation. Right? Whereas thalidomide, which is leading to phocomelia, is leading to proximal limb defect. So, number one drug which is associated with limb defects is thalidomide. Number two drug in which you are going to get certain limb defects, I will not call it as limb defects, but you will have to see the x-rays of the limbs to diagnose it. Right? That is why I have put it here, and that is warfarin. Now, in warfarin, actually what happens is, in warfarin, it leads to a defect in the growth of cartilage. Right? There will be a defect in the growth of cartilage. Now, because there is a defect in it is going to lead to defect in the growth of cartilage. So, there is going to be, wherever cartilage is present, there it will be defective, right? So, there can be a depressed nasal bridge, there can be choanal atresia, then there can be stippled epiphysis seen in femurs, stippled epiphysis seen in humerus, or stippled epiphysis seen in calcanei. Right? So that is why you may be shown an x-ray. Why I have included it in limb defects is because you will be shown an x-ray of the limbs and you will have to recognize warfarin embryopathy. Now, the name for warfarin embryopathy, it is also called as de Sala's syndrome. De Sala's syndrome. Right? And it chondrodysplasia punctata. Chondrodysplasia punctata. right? So in case of warfarin embryopathy, the cartilage is affected, so there will be choanal atresia, there can be stippled epiphysis, there can be depressed nasal bridge, and in 50% cases you will also get CNS abnormality. It is seen maximum when warfarin is used between 6 to 9 weeks of pregnancy. So whenever you get an X-ray where they are showing you the limbs, look at the epiphysis. And if this image is not very clear to you, but if you look over here, you will see stippled epiphysis. Right? So you are going to get stippled epiphysis in the areas of femur, in the areas of humerus and calcaneum. So if you are getting stippled epiphysis, then the drug which the mother might have used during pregnancy is warfarin. So warfarin is contraindicated during pregnancy, especially in first trimester. But there are latest recommendations which say that if the dose of warfarin is less than 5 milligrams per day, then it may be used in first trimester also. Right? Normally it is said that if warfarin shouldn't be used in first trimester, but now the latest recommendations are that if dose of warfarin is less than 5 milligrams per day, you may use it in first trimester. Now look at this image over here. You are getting a depressed nasal bone. Right? And you are getting, so depressed nasal bone you are getting over here. This is what is seen in warfarin embryopathy. So they are going to show you an image of depressed nasal bone. They are going to show you an X-ray where you're going to get stippled epiphysis. And that is how you are going to recognize warfarin embryopathy. Right? Then, drugs which are associated with cardiac defects. Now, the drugs which are associated with cardiac defects, that is lithium. Now, lithium, it leads to Epstein anomaly. Lithium leads to Epstein anomaly. Now, in Epstein anomaly, see this over here is a normal tricuspid valve. So, in a tricuspid valve, you have the anterior leaflet, the posterior leaflet, and the septal leaflet. Now, what happens in Epstein anomaly is that the posterior and the septal leaflet, they displace downward. Right? So there is downward displacement of the posterior and the septal leaflet, because of which there is tricuspid regurgitation, and because of which there is atrialization of the right ventricle. So such babies, when they will be born, they will be having cyanosis and heart failure. So they can show you an echo. And in echo, you will see ARV written. So in the echo, you will get ARV written, that is atrialization of the right ventricle, right? And there will be a pointer which is going to point towards the tricuspid valve, right? So if your question is showing you an image of echo, where there is, ARV written, atrialization of the right ventricle written, or you can see regurgitation of the tricuspid valve, and they ask you, and they say that the child is born with cyanosis and heart failure, what drug do you think the mother would have taken? Then she would have taken lithium. Then, the next drug which can lead to cardiac defects is SSRI, selective serotonin reuptake inhibitors. The most teratogenic selective serotonin reuptake inhibitor is paroxetine. And most common system which is involved when paroxetine is taken is cardiovascular system. Most common cardiac defect which you get with the use of paroxetine is atrial septal defect. Right? So in all pregnant females who are taking SSRIs, especially paroxetine, you should do a fetal echo to rule out atrial septal defect. Right? So for limb, I told you that for limb, you are going to see the drugs which lead to limb defects are thalidomide, and limb X-ray you are going to get in warfarin embryopathy. Cardiac defects the drugs which can lead to cardiac defects are number 1, lithium, and number 2, SSRIs. Now there are certain drugs which lead to cardiac defect, and they also lead to facial dysmorphology. Now, drugs which lead to cardiac defects and facial dysmorphology, they are two drugs. Number one, isotretinoin, and number two, phenytoin, which leads to fetal Hayden-Twin syndrome. Right? Same thing happens with alcohol as well. Even alcohol is going to lead to cardiac defects, plus there will be facial dysmorphology. Right? Now, in case of isotretinoin, there will be cardiac defect. There will be facial dysmorphology in the form of cleft lip, cleft palate, or microtia, the ear problems, microtia, anotia, and micrognathia. Right? Then there will be CNS defects and thymus defect. Now, this thymus defect and microtia, anotia, along with cardiac defect, this is very peculiar of isotretinoin, right? So in case of phenytoin, the facial defect which you get is limited to the midface, right? You can never get microtia or anotia in case of phenytoin. But if you are getting microtia or anotia, or if you are getting thymus is involved and there is a cardiac defect, then it has to be the use of isotretinoin. Right? In case of phenytoin, you are going to get facial dysmorphology, plus you are going to get limb defect plus cardiac defect. So facial dysmorphology plus limb defect plus cardiac defect means we are talking about phenytoin. But please remember that fetal Hayden-Twin syndrome has a very, very close resemblance to fetal alcohol syndrome. Right? Both of them have got very close resemblance. One feature which may help you in differentiating whether they are talking about fetal Hayden-Twin syndrome or whether they are talking about fetal alcohol syndrome is one, obviously, on history. Right? So substance abuse history, if it is present, then it means that they are talking about fetal alcohol syndrome. If your patient is having epilepsy and an anti-epileptic drug was given, because of which the problems are there, the facial dysmorphology is there and cardiac defect is there, then it means they're talking about fetal Hayden-Twin syndrome. But another very important feature which may help you in distinguishing between the two is this limb defect. Now again, in phenytoin, there is a distal defect. The nails of the baby will be small and they can be hypoplastic phalanges. So this distal limb defects involve where the nails are small, the digits are small, there are hypoplastic phalanges. They are seen in fetal Hayden-Twin syndrome and they are not seen in fetal alcohol syndrome. As far as the facial dysmorphology is concerned, just now I was telling you that phenytoin is going to lead to mid-facial dysmorphology. So mid-face is going to get involved and you are going to see that such babies will have flat faces, middle part of the face will be flat, then they can have depressed nasal bridge, then their upper lip, the vermilion border of the upper lip will be thin, they can have a smooth philtrum, then their nose can be a depressed nasal bridge and they can be upturned nose, short nose, cleft lip, cleft palate, and they can have ocular defects like ptosis and hypertelorism. Right? So, smooth philtrum is again a feature which is seen there in alcohol. It may be seen in phenytoin also. In phenytoin, definitely you are going to get a thin vermilion border and long upper lips. Right? So, if you are getting facial dysmorphological features along with cardial septal defects and you are getting distal phalanges hypoplasia, you are getting small nails, then that means we are talking about the fetal Hayden-Twin syndrome. Yes? Okay, so cardiac defects seen with 4 drugs. Number 1 was lithium, number 2 was paroxetine, number 3 was isotretinoin, where you're going to get thymus will be involved and microtia and anotia are going to be present in facial dysmorphology. And number 4 is fetal Hayden-Twin syndrome. Number 5 is fetal alcohol syndrome, which we are going to do as a separate entity, right? Then, drugs which are associated with nerve palsies in the fetus. So number 1 is misoprost. Misoprost, it leads to Mobius syndrome. In Mobius syndrome, you get 6th and the 7th nerve palsy and again there are limb reduction defects. So please remember that because misoprost can lead to sixth and the seventh nerve palsy, that is why misoprost should never be used in first and second trimester. In third trimester, we are using misoprost and it can be used for cervical ripening. So suppose we have a pregnant female and she says that I do not want to continue with this pregnancy, and you've done a medical abortion in her. You've given her methotrexate and you have given her misoprost. But abortion didn't happen, and she says, since abortion hasn't happened, let me continue with the pregnancy. Are you going to make her continue with the pregnancy? Let her continue with the pregnancy? No, you are not going to let her continue with the pregnancy because she has eaten misoprost. Misoprost leads to Mobius syndrome. She has taken methotrexate. It leads to methotrexate aminopterin syndrome. Methotrexate aminopterin syndrome, right? In methotrexate aminopterin syndrome, again, there are features of facial dysmorphology where you get typical things like clover leaf skull, microcephaly, depressed nasal bridge, depressed supraorbital ridges, micrognathia, low set ears, and limb deformities. You don't need to remember all these things. You simply need to remember that methotrexate is going to lead to facial dysmorphology along with limb defects, whereas misoprost, it leads to sixth and seventh nerve palsy, that is Mobius syndrome. By the name of Mobius syndrome, questions have been asked, and that is why we are never going to let a female in whom abortion didn't happen, we are not going to let them continue their pregnancies, right? Now, drugs which lead to decreased urine output in the fetus, we have ACE inhibitors and trastuzumab. ACE inhibitor and trastuzumab, they lead to fetal renal hypoperfusion, because of which there will be decreased urine output, and because of the decreased urine output in the fetus, the decreased urine output is not only going to be there in the fetus, in the neonate also there is going to be oliguria and anuria when the baby will be born. But because of fetal oliguria, there is going to be oligohydramnios, and oligohydramnios, what all can oligohydramnios lead to? Oligohydramnios can lead to pulmonary hypoplasia. It can lead to limb reduction defects. So it can lead to pulmonary hypoplasia and it can lead to limb reduction defects. Right? So we have drugs which lead to decreased urine output, ACE inhibitors and trastuzumab. Then phenytoin, facial dysmorphology. Now, drugs which lead to facial dysmorphology, just now I told you methotrexate leads to facial dysmorphology, phenytoin leads to facial dysmorphology, isotretinoin leads to facial dysmorphology, alcohol leads to facial dysmorphology, and glucocorticoids. Please remember, rarely if you are using glucocorticoids at less than 10 weeks of gestation, it may lead to cleft lip and cleft palate. Normally, we are using glucocorticoids for lung maturation, and that is used at a later week of gestation, right? But in cases of congenital adrenal hyperplasia, we have to use glucocorticoids, and it has been seen that rarely glucocorticoid use at less than 10 weeks can lead to cleft lip and cleft palate. Now, what are the drugs which are linked to cancer? One very important drug is linked to cancer, and that is diethylstilbestrol. DES stands for diethylstilbestrol. Diethylstilbestrol. Right? So diethylstilbestrol, it was an estrogen which was being used earlier. In earlier days, we used to use this estrogen during pregnancy. And it was seen that if this estrogen is used during pregnancy, then if the mother is carrying a female fetus, it leads to clear cell adenocarcinoma of the vagina and clear cell adenocarcinoma of the cervix also. So it leads to adenocarcinoma of vagina and adenocarcinoma of the cervix. It can lead to hypoplastic uterus. It can lead to T-shaped uterus. It can lead to breast cancer, and it can lead to premature menopause. Right? So all these things could happen if diethylstilbestrol exposure happened in utero in a female fetus. So it is linked to cancers, the adenocarcinoma of vagina and adenocarcinoma of cervix, breast cancer it is being linked to premature menopause, hypoplastic uterus and T-shaped uterus. One anomaly which is never seen in a female fetus who has been exposed to diethylstilbestrol is renal anomaly. A female fetus who is exposed to DES never gets renal anomalies. This is in contrast to a male fetus. So if the pregnant female who has taken diethylstilbestrol, if she's carrying a male fetus, then there are increased chances of hypospadias, cryptorchidism and renal defects. So renal defects are seen in a male fetus who has been exposed to diethylstilbestrol. Renal defects are not seen in a female fetus exposed to diethylstilbestrol. Now, don't ask me the reason why. This has been seen and I'm telling you this fact, right? Now, alcohol-related birth defects. Now, whatever I'm teaching you about alcohol-related birth defects, I am telling you from Williams 25th edition, page 239. Now, in Williams, they have said that fetal alcohol syndrome, it is going to happen only if a female is consuming more than equal to 6 drinks per week for 2 weeks. So, for 2 continuous weeks, she is having more than equal to 6 drinks in a week, right? Or on a particular occasion, she is having more than equal to 3 drinks, and this she takes on 2 occasions. On 2 occasions, she is taking more than equal to 3 drinks, then that leads to fetal alcohol syndrome. Please remember, binge drinking is more dangerous in a pregnant female, right? Now, in fetal alcohol diagnostic criteria, you can remember the mnemonic Goa's famous beer bar, where G stands for growth impairment. So whenever you are going to get a question on fetal alcohol syndrome, you are going to see that the clinical vignette is telling you that the baby has growth retardation, number 1. Number 2, there will be facial dysmorphological features of facial dysmorphology. And features of facial dysmorphology, they closely resemble the features of fetal Hydantoin syndrome. In other words, there is going to be a thin vermilion border. Then the philtrum, this over here. This philtrum is very indistinct. Then there can be a low nasal bridge, then micrograthia. So all these features which you were seeing there in fetal Hydantoin syndrome, you may get about facial dysmorphology you can get here. So your question is going to say that number 1, there is growth retardation. There are facial dysmorphological features like a smooth or indistinct philtrum, like there can be a thin vermilion border and a small palpebral fissure. These are the 3 which are included in diagnostic criteria. Out of these 3, any 2 should be present. Small palpebral fissure, then a thin vermilion border, then a smooth philtrum. Right? So if 2 or more than 2 of these 3 are present, then we say that yes, it is facial dysmorphological feature related to alcohol. Although other things can also be seen, epicanthal folds can be seen, micrograthias can be seen, cleft lip and cleft palate can be seen with fetal alcohol, but they are not in the diagnostic criteria. In fetal alcohol syndrome, in the diagnostic criteria, we have only 3 facial dysmorphological features, and they are a thin vermilion border, indistinct philtrum and small palpebral fissures, right? Then the third thing they are going to tell you is that the baby's head circumference is small, right? So there is abnormal brain growth or physiology, right? So head circumference of the baby is small, or the baby is showing, once the baby is born, they can be recurrent non-febrile seizures, and behavioral impairment is there. So your clinical vignette is going to come in such a manner that they are going to tell you about facial dysmorphological features. Along with that, there will be growth restriction. Along with that, they are going to mention that head circumference was less than 10%, and yes, cognitive development is delayed. That can be mentioned. Most of the times it will be mentioned as mental retardation. Right? So if these features are present, then we say it is fetal alcohol syndrome. In fetal Hydantoin syndrome, it was the distal limb involvement. For example, there were hypoplastic phalanges and small nails, which was distinguishing fetal Hydantoin syndrome from fetal alcohol syndrome. Right? Now, in fetal alcohol syndrome, apart from the diagnostic criteria, it doesn't mean you don't get cardiac defects. You may get cardiac defects, you may get renal defects, you may get skeletal defects, eye defects, and ear defects as well. But they are not included in the diagnostic criteria. Right? Okay. So that was about the drugs which I wanted you to know. I know it is a little too much, but then that is the requirement. You are going to give an exam where they can ask you any clinical question, and to be prepared for any clinical question which is being asked, you should know about these drugs and how these drugs are going to affect pregnancy. Not only this, in your clinical practice also you should be knowing that how giving these drugs would affect the pregnancy. Right? Now coming to teratogenic infections. Now in teratogenic infections, the first infection which I'm going to talk to you about is a cytomegalovirus infection. Now cytomegalovirus is a DNA virus, and two very important questions regarding cytomegalovirus. It is the most common congenital infection, number one. Right? Number two, it is the most common cause of sensory neural hearing loss in neonates. Right? So it's the most common congenital infection. It is the most common cause of sensory neural hearing loss. Right? Now, in cytomegalovirus, please remember, virus infection, it does not give lifelong immunity. This is in contrast to all other infections where if infection has happened once and antibodies are present, it confers a lifelong immunity, right? So if a pregnant female has already had cytomegalovirus, it does not mean that in this pregnancy she cannot have a cytomegalovirus infection. So if a pregnant female is getting cytomegalovirus infection, either it could be a primary infection or it could be a recurrent infection. But remember that chances of vertical transmission are there with primary infection. With a recurrent infection, the chances of vertical transmission are hardly 1%. Right? That is another very important point which you have to remember about cytomegalovirus infection. So suppose there is a pregnant female and she has got cytomegalovirus infection. What hint in the question is going to tell you from history that probably it's a cytomegalovirus infection? This female will have had a close contact with toddlers. So the question is going to tell you that this patient was either working in a nursery or she was working in a crèche, right? Or if she has a baby at home. So if a pregnant female has had close contact with a toddler, then the chances of cytomegalovirus are high. Infection are high. Most of the females are asymptomatic. Only in 10 to 15% cases you get flu-like symptoms, fever and lymphadenopathy. Now, if a pregnant female has a cytomegalovirus infection, then what is the most common time of transmission of a cytomegalovirus infection? Please remember, the most common time of transmission of cytomegalovirus is third trimester. So cytomegalovirus, the most common time of transmission is third trimester. You don't need to know any other thing over here. Just the most common time is third trimester. Right? When a pregnant female gets cytomegalovirus infection, it is not necessary that every pregnant female who has cytomegalovirus infection is going to, vertical transmission is going to happen in every pregnant female, and it is not necessary that vertical transmission results in congenital cytomegalovirus syndrome in all the fetuses who have been infected. Congenital cytomegalovirus syndrome is seen only in 5 to 10% patients. So I'm writing this over here, this line. I'm just writing it here so that it becomes easier for you. Congenital cytomegalovirus syndrome is seen only in 10 to 15% patients. Right? Only in 10 to 15% fetuses you are going to get congenital cytomegalovirus syndrome. Right? So in cytomegalovirus infection, it was important. What is the time for infection, vertical transmission? Maximum time for vertical transmission is third trimester, number one. Congenital cytomegalovirus syndrome is going to happen only in 10 to 15% cases, and it is going to happen. And when it is going to happen, what are the features you are going to get? You are going to get CNS calcifications. These CNS calcifications will be periventricular calcifications. There will be microcephaly. There will be eye lesions like chorioretinitis or retinopathy, intellectual disability, and sensory neural hearing loss. Right? Now, intellectual disability is seen in rubella also, it is seen in toxo also, it is seen in cytomegalovirus also. Right? Then eye lesions is also seen in all three of them, in which eye lesion of rubella is a little specific thing, like you get cataract, but in toxo also and in cytomegalovirus also you get chorioretinitis. So that is also not a distinguishing feature. As far as calcifications are concerned, calcifications you see in toxo and you see in cytomegalovirus most commonly. In cytomegalovirus you get periventricular calcifications. In case of toxo you get intracerebral calcifications. Right? And you are going to get sensory neural hearing loss here. Clear to all of you? Yes. So, most of the times, how are you going to come to the diagnosis that they're talking about cytomegalovirus? Number one, on the basis of history that the pregnant female had been in close contact with toddlers. Number one. Number two, this sensory neural hearing loss. As I told you that this is the most common cause for sensory neural hearing loss. So when they are talking about congenital, whenever they are talking about cytomegalovirus, they have to mention sensory neural hearing loss. Right? Now you will say that, ma'am, sensory neural hearing loss is seen in rubella also. But then in rubella, there are certain other characteristic features which are not seen here. So if you are getting calcifications, if you are getting sensory neural hearing loss, and along with it anything could be mentioned. It could be mentioned that there is microcephaly. It could be mentioned that there is chorioretinitis. There is mental retardation. Then you have to think they are talking about cytomegalovirus infection. Now, cytomegalovirus vertical transmission can happen, during pregnancy. Yes, and in pregnancy, transplacental transmission is going to happen maximum in third trimester. Then other modes by which cytomegalovirus can go and infect the fetus is during labor and during breastfeeding. But the most important one is transplacental spread, and maximum transplacental spread happens in third trimester. Is this clear to all of you? Yes, any confusions over here? Now, if there is no confusion over here, let us also talk about the diagnosis of cytomegalovirus. The diagnosis. Now, how am I going to know that congenital infection has happened? Right? So for that, first I should know that whether maternal cytomegalovirus infection has happened or not. And how am I going to know that maternal cytomegalovirus infection has happened or not? I am going to test IgM and IgG antibodies against cytomegalovirus. Right? Now, if IgM is positive, generally it indicates recent infection. And if IgG is positive, it indicates past infection. Right? This is something which you know from your microbiology also. So suppose you have a case 1 where IgM is negative and IgG is positive. Then you are going to say that this is a case of past infection of cytomegalovirus. This patient did not get cytomegalovirus during pregnancy. Right? Okay. Then there can be a second case. Second case could be that your IgM is positive and IgG is negative. Now, if IgM is positive and IgG is negative, that means it is a recent infection. Right? Now, they can be a third case as well. A third case could be that IgM is also positive and IgG is also positive. Now what? If IgM is also positive and IgG is also positive, now what am I going to do? See, it could be that this IgM is continuing from a previous infection and just now the IgM is coming out to be positive from a previous infection as well, right? So in this case comes the importance of doing avidity test. Avidity test. Remember, in avidity test, if it is low avidity means less interval between infection and the test, right? So it indicates a recent infection. And if there is high avidity, it means high interval, long interval between the test and the infection. So this indicates remote infection. So, in this case, what I'm going to do is, I can get two types of results. I can get IgM positive, IgG positive with low avidity. Right? Low avidity means recent infection. Right? Or I can get IgM positive, IgG positive and a high avidity. If I am getting a high avidity, that means it's a remote infection. Now, whenever you are getting recent infection in the mother, now I am worried about the fetus, that whether fetus is infected or not. So whenever you get recent cytomegalovirus infection in mother, in pregnant female, that is an indication for doing amniocentesis. Why am I doing amniocentesis? I am doing amniocentesis so that I take out amniotic fluid, and this amniotic fluid I am going to do a PCR or a nucleic acid amplification test to know whether congenital infection is present or not, whether the fetus has been infected or not. And simultaneously, I will do an ultrasound for congenital malformations in the fetus. Right? Is this clear to all of you? This is how is the diagnostic protocol for cytomegalovirus infection during pregnancy. Right? Is this clear? Any confusions over here? As I told you, in cytomegalovirus, it's very, very important to know the time of transmission, which is the 3rd trimester. Then in cytomegalovirus, a pregnant female will have history of coming in contact with the toddlers. There will be sensory neural hearing loss in the baby. There will be intracranial calcifications. Along with that, there is going to be microcephaly, eye lesions. All of them can be seen. Yes? Then comes toxoplasma infection. Now, toxoplasma is caused by Toxoplasma gondii, and Toxoplasma gondii is an obligate intracellular protozoan parasite in where the cat is the definitive host. Right? This is something which Shivika ma'am has told you about Toxoplasma gondii, and you know about Toxoplasma gondii more than me. So common sense tells me that if there is a question related to Toxoplasma gondii, what history am I going to get? I am going to get history of the pregnant female coming in contact with cat feces. Right? So either she would be having a cat at home, right? Or it could be that she has taken undercooked meat during pregnancy. So if you are getting history of eating undercooked meat, or if you are getting history of coming in contact with cat feces, then it points towards Toxoplasma infection. Now, Toxoplasma infection, again, the most common time of transmission of Toxoplasma infection, like cytomegalovirus infection, is 3rd trimester, but the most severe infection happens during 1st trimester. Most severe is going to happen during 1st trimester. Most common infection, the maximum rate of transmission of Toxoplasma is during 3rd trimester. Now, in Toxoplasma infection, again, what are the things which I am going to get? I am going to get CNS calcifications. This time it will be intracerebral calcifications. I am going to get hydrocephalus. chorioretinitis, and IUGR. So this is the tetrad which you get. You get a CNS calcifications, hydrocephalus, chorioretinitis, and IUGR. As I told you, intellectual disability is seen mostly with all the torch infections. Right? Now, in toxoplasma infection, the thing is, if mother has toxoplasma infection in pregnancy, for treating the mother, what is the drug of choice? What is the drug of choice for treating mother with a toxoplasma infection? It is spiramycin. But please remember, spiramycin cannot cross the placenta. And again, diagnosis is based on IgM, IgG and avidity tests. And if you get these positive, if you get that yes, recent infection is present, you are going to do amniocentesis. That is common for everywhere. You are going to get an amniocentesis done. And based on amniocentesis, you are going to take out amniotic fluid, do a PCR or a NAT test, and you are going to see whether fetal infection is there or not. And simultaneously, you have to do ultrasound. That is common for everything. Every infection, right? Now, in mother, to treat toxoplasma during pregnancy, the drug of choice is spiramycin, but spiramycin, it does not cross the placenta. Spiramycin does not cross placenta. That is why if I come to know that fetal infection is present, I will have to give a drug which can cross the placenta, and that is pyrimethamine plus sulfadiazine combination. Pyrimethamine and sulfadiazine combination for treating the fetal infection. When you are giving these drugs, you are going to keep in mind that they are folic acid antagonist. So you have to supplement folinic acid while you are using these drugs. And please remember, sulfadiazine, if you are using in patients with G6PD deficiency, it can lead to hemolysis. Right? So if fetal infection is also present, in that case, you have to alternate spiramycin with pyrimethamine and sulfadiazine combination. What do I mean? You have to alternate. For 3 weeks, you have to give spiramycin. Then for 3 weeks, you have to give pyrimethamine sulfadiazine combination. Why? Because I have to treat both maternal and fetal infection. So I'm going to alternate these drugs. For 3 weeks, one drug, then 3 weeks, second drug. Then 3 weeks, one drug, then 3 weeks, second drug. To treat maternal as well as fetal infection. Right? Only for maternal infection, it's spiramycin. Clear to all of you? Okay. Third torch infection, which is highly teratogenic, which is the most teratogenic congenital infection, is rubella, which is RNA virus. Now, in rubella, maximum transmission of rubella, it happens in first trimester. Right? In cytomegalovirus and toxoplasma, maximum transmission happened in third trimester. In rubella, maximum transmission happens in first trimester. And please remember, when a pregnant female is acquiring rubella, then up till 16 weeks of pregnancy, if she is acquiring rubella, then it is very teratogenic. So, maximum transmission also in first trimester. Most teratogenic also in first trimester. In first trimester also, first 2 months are maximum teratogenic. Right? And if a mother acquires rubella infection in first trimester, that is an indication for doing MTP. Why? Because rubella is the most teratogenic infection and its maximum teratogenicity is seen in first trimester. Maximum transmission is seen in first trimester. So write this point down, that if a pregnant female, she acquires rubella in first trimester, then that is an indication for doing MTP, because rubella in first trimester, specifically up till 16 weeks, Up till 16 weeks of pregnancy, it can lead to congenital rubella syndrome. And in congenital rubella syndrome, there are certain peculiar features which you get. One of the peculiar feature is heart disease. This is the only congenital infection where you're going to get heart disease like pulmonary stenosis and patent ductus arteriosus. Right? Apart from that, you are going to get cataract, you are going to get sensory neural hearing loss. Now, sensory neural hearing loss you were getting in cytomegalovirus also and in rubella also, but in cytomegalovirus you never get heart defects. In rubella, you get sensory neural hearing loss and you get heart defects. That's a thumb rule. If there is a congenital infection leading to heart defects, it has to be rubella. Specifically, it leads to PDA and pulmonary stenosis. Apart from that, it can lead to microcephaly, it can lead to cataracts, it can lead to glaucomas. Clear to all of you? Yes. In the mother, how is rubella going to manifest? In the mother, rubella is going to manifest in the form of mild fever and a maculopapular rash. That is how mother is going to manifest rubella. Now, suppose rubella infection is happening beyond 16 weeks. Now, if rubella infection happens beyond 16 weeks, then it can lead to sensory neural hearing loss, and neonates who are born with rubella infection, they can show a neonatal purpura, radiolucent bone disease, hepatosplenomegaly, and sensory neural hearing loss. So that was congenital rubella syndrome. Congenital rubella syndrome is an indication for doing MTP, right? But suppose rubella infection is happening beyond 16 weeks, then when such a baby will be born, such a baby will have sensory neural hearing loss, may have, then neonatal purpura may be there, radiolucent bone disease can be there, and hepatosplenomegaly can be there. Another very important thing is that these neonates, they shed rubella infection, rubella virus for a very long time. So this neonate is going to shed rubella virus, and that is why this neonate who's born to a rubella infected mother, this neonate should not be placed with other neonates in the nursery, because it is going to shed the virus and it can spread it to the other infants who are there in the nursery. Now, a baby who's born with rubella, they can also have certain long-term consequences. The long-term consequences of rubella are panencephalitis, insulin-dependent diabetes mellitus, thyroid disorders, and precocious puberty. So this is one infection which can lead to precocious puberty. Right? So the long-term consequences are panencephalitis, thyroid disorders, diabetes mellitus, and precocious puberty. Right? So I have written this again, that all pregnant females in the first trimester, they should be screened for rubella infection, and if rubella infection is present, then MTP should be done. Now, my next question to you is that screening for rubella infection, it has to be done in all pregnant females in the first antenatal visit. And again, you are going to do a rubella antibody and avidity. So suppose you are getting IgM positive and IgG negative. That means in the first trimester, mother has got rubella. It's a recent rubella which is there in first trimester. So that means I'm going to advise her to undergo MTP. This is case number 1. Case number 2 is IgM negative, IgG positive. This means that this person either had a past infection of rubella or she is vaccinated against rubella. Right? So, no problem over here. You will do a routine antenatal care. You will give her routine antenatal care. She's going to continue her pregnancy. Now comes case 3. Case 3 is if IgM is negative, but you see that IgG is also negative. This means this person is not vaccinated against rubella. she's not vaccinated against rubella. Now, please remember, even if she's not vaccinated against rubella, rubella vaccination is contraindicated in pregnancy. So, I cannot do anything, right? Rubella vaccination is contraindicated in pregnancy. I am going to advise her that after delivery, she should get vaccinated if she's planning a next pregnancy, right? So, my advice to her will be, after delivery, get vaccinated. After delivery, get vaccinated if she plans another pregnancy. If she is planning another pregnancy after delivery, she should get vaccinated. Do not say that I'm going to vaccinate her in this pregnancy. Rubella vaccination is contraindicated during pregnancy because it's a live vaccine. Now, my next question to you. So, after giving rubella vaccine, for how long is pregnancy contraindicated? So, after giving rubella vaccine, pregnancy is contraindicated for 1 month. Now, suppose within 1 month of rubella vaccination, a female gets pregnant. A female conceives. Right? So, I told her not to get pregnant within 1 month of this vaccination, but by chance this female has conceived. Well, now what is the next step? Please do not say that I'm going to do MTP. It is not an indication for doing MTP. Rubella infection in first trimester is an indication for MTP. Rubella vaccination is not an indication for doing MTP. You are going to continue her pregnancy. Right? By chance, if a female becomes pregnant, that's okay. Clear to all of you? Yes? So tell me, which infection is associated with congenital heart disease? Rubella is associated with congenital heart disease. In which infections were you getting intracranial calcifications? In cytomegalovirus and in toxoplasma. Periventricular calcifications you were getting in cytomegalovirus. And it was associated with microcephaly. Intracerebral calcifications you were getting in toxoplasma, and it was associated with hydrocephalus. Sensory neural hearing loss is caused by 2 infections. Most commonly, it is caused by cytomegalovirus, and then it is also caused by rubella. Cataract, if you are getting, you see it in rubella. Clear to all of you? Now, next infection, which is teratogenic, is parvovirus B19 infection. Let us talk about this infection. Now, parvovirus B19 is a DNA virus, and this virus, it replicates in the erythroblast precursors. Because it is replicating in erythroblast precursors, that is why parvovirus B19 infection leads to fetal anemia. Right? Now, parvovirus B19 infection, the pregnant female is going to give you a typical history of coming in contact with school-going children. So in cytomegalovirus, it was toddler's history which you were getting. In toxoplasma, you were getting history of coming in contact with cat feces or undercooked meat. In rubella, you are getting history of coming in contact with school-going children. Right? Now, all of you know about parvovirus B19 infection. It is called as the 5th disease. It is generally seen in school-going children, and in school-going children, you get a slabbed cheek appearance. So the entire cheeks are very red as if slap has been given. The nose is spared. Then on the trunk, you get a lacy net-like pattern of rash. And so this is what you get in the school-going children. Right? So in a pregnant female with parvovirus infection, again, you may get a slapped cheek appearance rash. You may get this rash. You may get a lacy reticular rash on the trunk. Plus, Due to fetal anemia, there is going to be increased urine production by the fetus, and so mother is going to have polyhydramnios. So in the pregnant female, you are going to get polyhydramnios. That's very, very typical. So in your question, they are going to say that fundal height is more than the period of gestation. Mother, they are going to say that female had come in contact with school-going children. Her fundal height is more than the period of gestation. She has a rash which is present on the cheek or on the trunk area. And you may also get history of polyarthralgias. Polyarthralgias, joint pains, right? This kind of history you are going to get in the mother, right? Then I should suspect that they are talking about parvovirus B19 infection. Now, parvovirus B19 infection is the most common infectious cause for hydrops fetalis. It's the most common infectious cause for hydrops fetalis. So, once a mother has got parvovirus B19 infection, then the fetus, it can lead to abortions, it can lead to stillbirth, it can lead to non-immune hydrops fetalis, it can lead to fetal anemias. Right? So you can get fetal anemias, you can get non-immune hydrops fetalis, you can get stillbirth, or you can get abortions due to parvovirus B19 infection. Right? Although I am including it over here, it does not lead to any birth defect. It leads to hydrops fetalis and it leads to fetal anemia. So birth defects are not seen over here. And as I told you, teratogen doesn't mean always birth defect. Teratogen could also be any functional defect. So a defect either in the form or function is a teratogen. So definitely parvovirus B19 is a teratogen which is leading to fetal anemia, which is leading to non-immune hydrops fetalis, which can lead to abortions and which can lead to stillbirths. Right? Now, about hydrops fetalis. So, most common infection causing hydrops fetalis is parvovirus B19 infection. The chances of hydrops fetalis are maximum if mother acquires parvovirus between 13 to 16 weeks of pregnancy. So, that is the time when chances of hydrops fetalis are maximum. So if mother is getting infected between 13 to 16 weeks of pregnancy, then the chances of hydrops fetalis are maximum. And once mother acquires the infection, it takes around 10 weeks for hydrops fetalis to happen. So the moment I come to know that my patient has parvovirus B19 infection, for the next 10 weeks, that's a very, very crucial time for me to evaluate whether hydrops fetalis has developed or not, right? Why is this period 13 to 16 weeks very important for that leads to hydrops fetalis? Because this is the period which coincides with hepatic hematopoiesis. Right? That is why this period, if mother acquires infection in this period, then it can lead to fetal anemias and hydrops fetalis. Clear? So when mother is diagnosed with parvovirus infection, next 10 weeks are very important because in the next 10 weeks, fetus can have non-immune hydrops fetalis, and that is why every 2 weeks I'm going to do a targeted scan. Every 2 weeks, I'm going to do a targeted scan, and in order to know whether fetal anemia has developed or not, I am going to do a peak systolic velocity of middle cerebral artery. Please remember this, that for fetal anemia, always the Doppler which you do is Doppler of middle cerebral artery. And what do you see in this Doppler? You are going to see the peak systolic velocity. That is PSV. And if peak systolic velocity is more than equal to 1.5 mmol, then that is severe anemia. Right? So, Again, I'm telling you, parvovirus B19 infection is the most common infectious cause of hydrops fetalis, and maximum chances of hydrops fetalis are when mother acquires parvovirus infection between 13 to 16 weeks, because that is the time for hepatic hematopoiesis. And once you come to know that your patient has parvovirus B19 infection, next 10 weeks are very, very important. Every 2 weeks you have to do a targeted scan, and to check for fetal anemia, you will have to do a peak systolic velocity of middle cerebral artery. When I'm going to talk to you about hydrops fetalis in the video on Rh negative, I'll tell you that hydrops fetalis is an ultrasound diagnosis. So, in order to know whether hydrops fetalis has developed or not, you will have to do an ultrasound. It's an ultrasound-based diagnosis. Hydrops fetalis is never a clinical diagnosis which you make, right? Then, the next infection which is important is varicella zoster in pregnancy. Now, in a patient, a pregnant female who is having varicella zoster infection, she is going to give you this history that she came in contact with a person who had chickenpox. Right? So a person who has had chickenpox through droplet infection, through skin-to-skin contact, the pregnant female can have chickenpox or varicella zoster infection during pregnancy. Now, if suppose there is a pregnant female who does not have varicella just now, but she has come in contact with a person who had chickenpox, how can you prevent the pregnant female from getting chickenpox? You can prevent this pregnant female from getting chickenpox by giving her varicella zoster immunoglobulin. And if the pregnant female has developed chickenpox, then the drug of choice is acyclovir, right? So, to prevent varicella zoster infection in a pregnant female, if she has come in contact with a person having chickenpox, you have to give varicella zoster immunoglobulin. And to treat varicella zoster infection in a pregnant female, you have to give acyclovir. Acyclovir, right? Now, please remember that what is the most common time when varicella infection is going to happen and when it is going to lead to congenital varicella syndrome? Most common time for varicella infection is between 13 to 20 weeks of pregnancy. Between 13 to 20 weeks of pregnancy. In other words, it is second trimester. Second trimester. So again, please, I want all of you to make this table and keep it with you. Varicella zoster maximum transmission, it is going to happen in third trimester. Toxoplasma's maximum transmission happens in third trimester. Rubella's maximum transmission happens in first trimester, especially less than 16 weeks, and especially most severe is also going to happen in first trimester, and it leads to congenital rubella syndrome. Then parvovirus infection, most severe when it is going to lead to congenital hydrops fetalis is non-immune hydrops fetalis is 13 to 16 weeks, that is second trimester. Then varicella infection. Maximum and most severe happens in second trimester. For toxoplasma, most severe happens in first trimester. Right? So, congenital varicella syndrome is going to happen when mother acquires chickenpox between 13 to 20 weeks. That is the time when maximum transmission happens, and that is the time when most severe transmission happens. Now, in congenital varicella syndrome, baby is going to have cicatricial skin lesions, right? So, that is what happens in congenital varicella syndrome. There are going to be cicatricial skin lesions, plus there will be limb deformities like contractures in the limb, and limb contractures or limb deformities, ocular deformities, then brain defects and microcephaly. The important point over here in congenital varicella syndrome is not brain deformity, it is not ocular defect. What is important is your Skin lesions, cicatricial skin lesions and limb contractures. Just now I told you cataract is seen in rubella. Now cataract is also seen in congenital varicella syndrome. Right? Brain atrophy. Brain atrophy is seen in congenital varicella syndrome, and brain atrophy, you are just now going to see that brain atrophy and microcephaly, they are also seen in Zika virus. That is how you will be able to remember infections. If you just think that I will be able to remember everything, you will not be able to remember everything. You will have to link it up and remember. So for congenital varicella syndrome, all of you are going to remember that it leads to cicatricial skin lesions. It leads to limb contractures. Right? Now, if you have made this table, now write one more point. So write cicatricial skin lesions. They are seen in two infections. Number one, varicella zoster infection, and number two, herpes infection. In herpes infection. Right? Then cataract also, if you are getting it in rubella, and you are also getting it in varicella zoster, congenital varicella zoster syndrome. Then brain atrophy and microcephaly. This is very, very peculiar feature, and more commonly it is seen in Zika virus, and it is also seen in congenital varicella syndrome. In congenital varicella syndrome, bachon, although brain atrophy and microcephaly can happen, but it is not the characteristic lesion, right? So examiner is not going to stress on brain atrophy and microcephaly. In congenital varicella syndrome, the examiner is going to stress on cicatricial skin lesions and limb contractures. Right? But in Zika virus, the examiner is going to stress on microcephaly and brain atrophy. Are you understanding this? Yes. So although brain atrophy and microcephaly can be seen here, but you have to remember that if you have got only this, that there is brain atrophy and microcephaly, please choose Zika virus as an answer. Right? Remember, if congenital varicella syndrome is present, again, it is an indication for MTP. So it is an indication for doing MTP if you have got congenital varicella syndrome. I am reading out what is written under manifestations so that if you cannot understand what I have written, you can, when I'm reading it out, you can write it down. So I have written congenital varicella syndrome between 13 to 20 weeks is most commonly seen. Right, and the incidence is 2%. There is cicatricial skin lesions or scarring, limb contractures or deformities, ocular defects like cataract and chorioretinitis, brain defects like cortical atrophy and microcephaly. Then I have written in the teratogenic period, I have written that it is teratogenic within 20 weeks. Right, and the most common time for teratogenicity is 13 to 20 weeks. I have also written in the teratogenic period that if congenital varicella syndrome is seen, it is an indication for doing MTP. In history, I have written that if there is in a pregnant female, you are going to get history of contact with a chickenpox patient, and from a chickenpox patient, the infection is going to come to the pregnant female by droplet infection or skin-to-skin contact. In the pregnant female, there will be fever and flu-like symptoms. There can be a rash, and all of you know that in chickenpox there is a vesicle which is present over a red base, and there is a pleomorphic rash. So you get rashes in various forms. Initially there is going to be vesicle, then there is going to be a papule, then there is going to be a macule, and then ultimately there will be crusting and it will be shedding off. So that is a typical word which is used for chickenpox rash, and that is pleomorphic rash. And we say that it is a dew drop over rose petal, right? So it is a vesicle which is seen over a red base. It is not written here, but I'm just telling you. So this is what you know from your derma knowledge also. Now this is an image of a baby who's born with congenital varicella syndrome. In congenital varicella syndrome, you are going to get skin lesions and there will be limb contractures, right? Now, As I told you that varicella zoster infection, one risk period for varicella zoster infection was between 13 to 20 weeks. The second risk period for varicella is for having chickenpox during pregnancy is 5 days before delivery and or 2 days after delivery. So if a pregnant female is getting chickenpox infection 5 days before delivery or 2 days after delivery, then by that time maternal antibodies are not formed, and because maternal antibodies are not formed, the neonate will not be protected, and now in 25 to 50% cases, it is going to result in neonatal varicella syndrome. Right? So congenital varicella syndrome, it happens between 13 to 20 weeks. Neonatal varicella syndrome, it happens if a pregnant female gets infection 5 days before delivery or 2 days after delivery. Now, in this case, when a baby will be born, again, baby is going to have a rash, which is very typical of chickenpox. So it is again going to be vesicle over a red base. Again, we can say that there is going to be a pleomorphic rash, and the neonate can develop pneumonitis, hepatitis, meningoencephalitis. Right? Now, please remember that if a pregnant female has varicella infection 5 days before delivery or 2 days after delivery and the neonate has not developed neonatal varicella syndrome, then to prevent the baby from developing this syndrome, you are going to give varicella zoster immunoglobulin. But if the newborn baby has developed neonatal varicella syndrome, then the drug of choice is acyclovir. This is similar to what I told you in pregnant female. In a pregnant female who's exposed to chickenpox and she herself hasn't got chickenpox till yet, you are going to give varicella immunoglobulin. If she gets chickenpox, then to treat chickenpox, you are going to use acyclovir. Right? So cicatricial skin lesions, they are seen in 2 congenital infections. They are seen in herpes and in varicella zoster. Now coming to herpes infection. Now in herpes infection, you are going to get multiple painful vesicles on the vulva and there are no rashes on other parts of the body. Now if you are getting multiple painful vesicles on vulva and there are no rashes on other part of the body, that means we are dealing with herpes genitalis infection. Herpes genitalis is caused by herpes simplex virus. The incubation period of herpes simplex virus is 3 to 12 days. Initially, the lesion is a vesicle and then it is going to get rupture and you are going to get multiple grouped tender ulcers. So initially they are going to be vesicles and then they are going to rupture. So you are going to get multiple tender ulcers and ultimately the margins of these ulcers are going to fuse with each other, and that is what is polycyclic erosions. Right? Now, in this case, along with these polycyclic erosions, you are going to get bilaterally enlarged inguinal lymphadenopathy plus tenderness will be present. So, inguinal lymph nodes will be enlarged, they will be tender, but there won't be any bubo formation. So, if you are getting this picture, and this is what was asked in your NEET 2021, that there are multiple painful lesions on the vulva and there is a polycyclic erosion, the inguinal lymph nodes are enlarged and tender, so we are dealing with herpes genitalis. Right? Now, the diagnosis for herpes genitalis, again, this has been taught to you by your dermatology faculty that it is done by a T-Zank smear where you are going to take fluid from the vesicle and this fluid from the vesicle, you are going to stain it under Giemsa stain and you are going to see multinucleated giant cells and you are going to get acantholytic cells plus the vesicle fluid, you are also going to send it for PCR and culture. Once you come to know that yes, your pregnant female has got herpes genitalis, you are going to give her tablet acyclovir for 7 days, 3 times in a day. Right? So you are going to give tablet acyclovir for 7 days because that is the drug of choice for treating herpes genitalis infection during pregnancy. Now, if patient has got active genital herpes infection during labor, then that is an indication for doing cesarean section. Now, I need to just give you a little more details over here. All of you know that whenever there is active herpes genitalis infection, just now I told you that the drug of choice will be acyclovir. So the moment I diagnose that my patient has herpes genitalis infection, I am going to start acyclovir, which I am going to continue for 7 days. Right? And then please remember, I am going to restart the treatment at 36 weeks and continue it till delivery. So that time you have to treat, plus for suppressive therapy, you have to restart the treatment at 36 weeks and continue it for 7 days. Right? This is if mother has got herpes genitalis or herpes simplex virus infection for the first time in pregnancy, if it is a primary infection. Always remember that the rate of transmission is maximum with primary infection than with recurrent infections, right? So if it is a recurrent HSV infection, then in that case, immediate treatment with acyclovir you may give or you may not give. But suppressive therapy has to be given at 36 weeks. Right? In primary infection, at that time also for 7 days, you have to give acyclovir, plus you have to give suppressive therapy starting from 36 weeks. In recurrent herpes simplex virus infection, you may not give therapy the moment when it has been diagnosed, but you have to give suppressive therapy at 36 weeks. That is one very important thing which you have to remember, apart from remembering the drug of choice. Right? Then you have to remember that, as I was telling you, that C-section is done if there is active genital herpes infection. This all of you know, that if active genital herpes infection is present, I'm going to do a cesarean section. But there is one more indication for cesarean section, that even if active genital herpes infection is not present, but HSV is present, I have diagnosed that yes, HSV is present, and there are prodromal symptoms like vulval pain or burning which are present. Right? So HSV is present elsewhere, but yes, vulval pain is there. So then in that case also, that is mandatory, cesarean section has to be done. Vagina, if you are undergoing, if suppose active genital herpes infection is not present and I am doing vaginal delivery, then again I have to take some precautions while doing vaginal delivery, and they are artificial rupture of membranes should be avoided, instrumental delivery should be avoided, fetal scalp pH monitoring should be avoided. So like you do in HIV patients, you avoid these things. Similarly, you are going to avoid even if active genital herpes infection is not present on the vulva or on the labia. If active genital herpes infection is present on vulva or labia, then definitely that's a call that you have to do a cesarean section. Right? Now suppose there is a herpes genitalis patient and a patient is having preterm labor. In patients who are presenting to you with preterm labor or who are coming to you with PROM or PPROM, like you manage a patient of preterm labor or PPROM, you manage them expectantly. So if a patient comes to you with PPROM or preterm labor, you manage them expectantly. Right? Now over here, the concern was that because, if the membranes are ruptured, suppose, and there is herpes infection, can I manage them expectantly? Yes, you can manage it expectantly because herpes infection is present on the genital area. It is not present inside the uterus. Right? So all cases of herpes genitalis infection who present to you with preterm labor or who come to you with PPROM, you have to manage them like you manage a patient without herpes. The only thing is you have to give antivirals to them. Right? So whatever protocol you do normally for preterm labor, whatever protocol you follow normally for PPROM, same protocol you are going to follow for a patient who has HSV infection and she's coming to you with PPROM or with preterm labor. As far as breastfeeding is concerned, breastfeeding is contraindicated only if active lesions are present on breast. So only in that condition breastfeeding is contraindicated, otherwise breastfeeding can be continued. Clear? So this is what you have to know about herpes simplex virus or herpes genitalis. What is the most common time for transmission of neonatal herpes? What is the most common time of transmission for this herpes infection? Most common time of transmission is during labor. And if a neonate is born and the neonate gets herpes infection, what all are you going to see in the neonate? In the neonate, you are going to get skin lesion. And what kind of skin lesions? Cicatricial skin lesions. That is, you are going to get scarring on skin. You are going to get eye lesions, like you are going to get microphthalmia, chorioretinitis. You are going to get mucocutaneous lesions. right? So in the baby, you are going to get cicatricial skin lesions. If the baby is born and baby has been infected with HSV, you are going to get lesions in eye and you are going to get lesions in the mucocutaneous areas, right? So this is what you have to remember about HSV infection. Last is Zika virus. Remember, Zika virus, it belongs to the family of flavivirus. Again, a question on Zika virus was asked in your INI set exam. See, these days recently we were facing the COVID pandemic. Now, earlier, around 2015-16, there was an epidemic of Zika virus which happened in Brazil. And at that time, it was seen that most of the babies who were born at that time, they had very small heads. They had microcephaly, right? And it was linked to Zika virus. Right? Now, Zika virus is a type of RNA virus which has got special affinity for central nervous system. Right? That is why we are a little worried about this Zika virus. Zika virus is a vector-borne teratogen. It is spread by the bite of Aedes mosquito. So, it is a vector-borne teratogen. Now, this Zika virus, so suppose there is a person who has Zika virus infection. Now, when mosquito is going to bite that person, this Zika virus from that infected person is going to come, it is going to be transferred by this mosquito from an infected person into the other person where the mosquito is biting. Right? Now, suppose this mosquito bites a pregnant female. Then this Zika virus is going to reach the blood of a pregnant female. Now, please remember that Zika virus, it has got affinity for certain kind of receptors, and these receptors are present on the skin. So, when a mosquito is going to bite a person who's not infected and this mosquito was carrying Zika virus, this Zika virus is going to get attached to the receptors which are present on the skin, and from there they are going to travel ahead and they have got affinity for central nervous system, right? So these receptors, they are TIM1 receptor and TAM-AXL receptors. TIM1 and TAM-AXL, which are present on the skin cells. So they are present on keratinocytes and fibroblasts. Right? So these receptors are present on skin cells. So now suppose a pregnant female has been bitten by Aedes mosquito, which was carrying Zika virus. So what all symptoms are you going to get in this pregnant female? In this pregnant female, you are going to get normal flu-like symptoms. So you are going to get fever, you are going to get cold, you may get a rash, you may get polyarthralgia, joint pain. Right? And because it has got affinity for central nervous system, you may get neurological syndromes like Guillain-Barré syndrome, or it may lead to myelitis. Right? Now this Zika virus in pregnant females, it is going to get attached to the TAM-AXL receptors and TIM1 receptors, which are also present on the Hofbauer cells of placenta. So these receptors, they are also present on Hofbauer cells of receptor, and from there, vertical transmission is going to occur and it is going to reach the CNS of the fetus. Right? And when it is going to reach the CNS of the fetus, it is going to lead to cortical matter atrophy and lead to microcephaly. So babies will be born with small heads, ventriculomegaly, intracranial calcifications, ocular symptoms like macular scarring, increased tone of the limbs, and congenital limb contractures. Example, clubfoot. Right? So have you understood the Zika virus? So go through the previous year INI set paper. This video is there on YouTube. In the previous year INI set, in last year June, that is June 2020 INI set examination, or November 2020 INI set, there was a question on Zika virus syndrome, Zika virus infection. So go and look at that question and see if, without me telling you the explanation, after that, that's a detailed explanation where I have given. So without me telling you the explanation, whether you were able to come to the conclusion of Zika virus infection or not. I know this topic was a little lengthy and it was a very theoretical topic, but then it is very, very important topic. Whatever I have said while explaining to you this topic, each and every line is a potential MCQ. Each and every line has been asked. So make proper notes and go through it twice or thrice. I have tried my best so that I can present to you this topic in a manner so that you remember it for a longer time. Right, just in case you have any reviews on this topic, please write to me at drsakshiarora@gmail.com, drsakshiarora@gmail.com. I will be waiting for your feedback. Thank you. Take care.